So the first one was very clearly we have understood that we classify irrespective of the etiology. They may be idiopathic or they may be secondary. We are classifying them similarly. Very important. First point. Second, when you have a nomenclature change, what happens is that sometimes names of the interstitial pneumonias are changed because we become more clear about their pathophysiology. There are a few such names which you have to understand. They are easier in the long run because they're talking about the pathophysiology. So, first easy thing will be we all are aware of desquamative interstitial pneumonia. It is a smoking related change. And the new name for it is an alveolar macrophage pneumonia, AMP. This is the term which is going to replace DIP, and it is doing so because it is more correct histopathologically. The desquamative interstitial pneumonia, we now know that there is no significant or there's no primary desquamation of the cells which is causing all this. There are macrophages which are filling up the alveoli and then causing these changes. So that's why you have your AMP in the alveolar filling disorders. Okay, so that's important. So that was the nomenclature change number one, AMP, right? And the next one is BIP. So now what has happened is that now they're talking about something known as BIP, which is bronchiolocentric interstitial pneumonia. So remember it like another pattern. Till now, we are basically somewhat aware about UIP pattern, usual interstitial pneumonia pattern, or NSIP, non-specific interstitial pneumonia pattern. Apart from these two major ones, now there is a BIP pattern. We'll talk about it in a little while. We'll see an example or so. You have to remember that it is an airway centric pattern. If you have an airway centric interstitial pneumonia, then this is the one. You are going to try and classify this as the pattern. Next, there is now a term which is idiopathic diffuse alveolar damage, which has replaced acute interstitial pneumonia. Again, acute interstitial pneumonia was kind of a misnomer because there can be acute exacerbations in normal IPs also. Suppose a patient has ILD and then there is an acute infection on top of it, or there's some kind of pulmonary edema on top of it. You cannot just call it acute interstitial pneumonia, right? You cannot call it AIP. That doesn't make any sense. So that's why now there is a term which is called idiopathic diffuse alveolar damage. So the name itself tells us that there is no cause. It's a primary problem. Second, it is diffuse. Third, it is an alveolar pathology. Again, if we are looking at it, again, so what happens here is that we call it alveolar, but the problem is that it is happening in the walls of the alveoli. Okay. So even though it is alveolar, but there are walls involved in this. The primary pathology is happening in the alveolar septae, the walls and the septae. We'll also discuss this one as we go further. But again, the name is to clarify that for AIP, that name is not adequate for calling it. AIP does not tell us anything about its nature, its progression, its pathophysiology. It's not a very helpful name. That is why it has been changed to idiopathic diffuse alveolar damage. Next, when we are trying to classify the ILD, we are going to call it either an interstitial lung disease, like an interstitial pattern, or we are going to call it an alveolar filling disorder. So the main problem is either within the alveoli or it is within the interstitium, right? Okay. Next, we have to figure out what is the diagnostic confidence interval. Yes, yes, yes. We are going to see some examples of each of them. And we'll have to read some salient points of each of these also. Otherwise, it's going to get problematic. The main thing to do for ILD is to keep seeing cases also. many of us are going to get cases in our practice. If you want, we can take a case discussion on ILD also, where you can try to attempt it also. Next is diagnostic confidence. Now we are pretty sure of our pattern, but how sure are we? So is there a leading diagnosis that meets the guideline criteria with more than 9 or has more than 90% confidence? So then you can easily give in a confident diagnosis. You can be more confident of the words that are you are using. Next, so we'll see some examples on the images, and then you can let me know when you want a case discussion. We can take that also. But before that, you'll have to read and create your base. Next, if we are not more than 90% confident or we don't have a leading diagnosis, then we have to know whether we have more than 50% confidence or not. Then we can have a little bit of high confidence or low confidence, depending on how sure we are. Are there some things which are clinically matching? Is there a BAL which is helpful? Or is there some other clinical thing which is helping us? How sure are we of this pattern? If we are not able to classify it, then we are going to call it unclassifiable ILD. Then we're going to tell them that, these are the differentials. So when you are writing your report, we'll just see a template in the end, which they suggest in this paper. So with that, we can write and tell our clinical colleagues that how sure we are. Okay. So now remember that these are the interstitial patterns. Usual interstitial pneumonia, non-specific interstitial pneumonia. Now the new one is bronchiolocentric interstitial pneumonia. These are the lesser talked about. There is a diffuse alveolar damage, pleuroparenchymal fibroelastosis, lymphoid interstitial pneumonia. Next, we have alveolar filling ones. So in alveolar filling disorders, these three are the more common ones. Respiratory bronchiolitis ILD, organizing pneumonia, alveolar macrophage pneumonia, the one which is a new nomenclature. There are few rare ones, there's a separate table, and then they can be combined patterns or patterns which we don't know. Okay. They will have causes which can be secondary or primary. I want you to remember one thing here. For UIP, idiopathic is not a problem. Idiopathic is rather more common. However, for NSIP, remember CTD related ILDs, connective tissue disorder related ILD. When I think of or when I say of NSIP, think of CTD. When I'm saying UIP, think of idiopathic cause and IPF. When I'm saying bronchiolocentric, airway centric, then think of HP, hypersensitivity pneumonitis. Airway antigens are going in and then they are causing this reaction. So it is going to be airway centered. Again, next thing, we'll see each of their major causes because once you have this pattern, you have to think of these things. So again, for BIP, you have to think about things which are going through the airway, inhalational exposures, aspiration, hypersensitivity pneumonitis. Medications can lead to two types, either a bronchiolocentric or NSIP. These are the more common of the two. For diffuse alveolar damage, there are multiple causes. If it is an idiopathic one, then that is the term which has now been replaced. This one has been replaced. Again, for PPFE, there are more secondary causes than there are for primary causes. If you remember it like this, then you will know that I have to first rule out a lot of secondary causes, then only I'm going to call it idiopathic. Then the chances of you being correct are higher. For Again, for LIP, I want you to remember connective tissue disorder. For RBILD, it has to be smoking, and so is for AMP. Now, next, let's look at each of these patterns a little bit. So, for UIP, just remember you are going to find basal. So, this is an example of UIP. Let's see the first image. For UIP pattern, you are going to have a basal, subpleural, predominant fibrosis, right? You are also going to get these multi-layered air-filled cystic structures, which is honeycombing. So for a definite UIP pattern, you need honeycombing, and you need this subpleural basal predominance of fibrosis. This is for definite UIP. Next, if we think of probable UIP, the only thing missing out of this description is honeycombing. If you find a subpleural predominance, this is a second case, you're finding the abnormality in the subpleural location. You are finding it in the basal uh, section, in the basal parts of the lung, and you're finding features of fibrosis. Now, what is the feature of fibrosis here? Here you are getting broncholectasis. If you look at the airway is getting dilated when it is going to the periphery. So that is not normal. That is happening because there is fibrosis. Once you have a, and you also have septal thickening, you have ground glass opacities. So all these are suggesting fibrosis here. You are getting a subpleural basal predominant fibrosis without honeycombing. This can now be called as a probable UIP pattern. We have to identify these two patterns. If we find anything other than these, then we have to think of alternate diagnosis. We cannot call it UIP. Especially if you find lung cysts or mosaic attenuation or anything, then it's all gone into alternate. उस टाइम पे if you have an alternate kind of diagnosis in your mind, then you need a lung biopsy. For UIP, we are pretty confident based on the CT findings, and that's why usually we will not go for a surgical lung biopsy. Excuse me. So you don't need this. You really don't need this because our pattern recognition for UIP is pretty good. The concordance levels are good. That's why either you can call it definite UIP or probable UIP. And if it fits in well, then you don't need to go ahead for a surgical lung biopsy. Next, if we have to look at NSIP. So now we all know that for NSIP, there are two types of NSIP. So they can be a cellular or a fibrotic. The reason why we have to think of these is because their prognosis is different. Prognosis is better for the cellular variety because it is reversible. In NSIP, what happens is that you are going to get a lower lobe predominant ground glass opacity. Depending on the amount of fibrosis, you can get either reticulations or tractional broncholectasis. Remember now that there can be subpleural sparing in up to 50% cases. This has been very specific for NSIP. So probably in this ground glass predominant disease, you cannot appreciate the subpleural sparing so much. But if you look at the fibrotic variety, you can see that this part of the lung is being spared. This is just below the pleura. This lung is pretty okay. But there is dilatation of the airways, there is septal thickening, there is ground glass at places. So this is a pattern where this is lower lobe predominant. These are our lower lobe sections. We are getting ground glass predominant finding in a non-fibrotic or cellular NSIP. And for the fibrotic NSIP, apart from the signs of fibrosis, we see that there is subpleural sparing. So subpleural sparing is helpful in differentiating. to call it NSIP. Important thing next is NSIP will usually be associated with CTD. So if there is, let's think of CTD associated ILDs, NSIP is very common, is usually the most common thing which you should think about. Other can be a combined pattern of NSIP and OP. But for RA-ILD, UIP is the most common pattern. Okay. For RA-ILD, UIP is the most common pattern. And for certain autoimmunes like Sjogren's, LIP is the most common pattern. So this has a kind of a poor prognosis. That's why. So for cellular NSIP, you have to remember that there has to be a lower lobe predominance and there has to be a predominant ground glass component. So they can be septal thickening, they can be ground glass. They're predominantly lower lobe. Okay. And as the amount of fibrosis increases, then you are going to get other changes. It's usually so. So you can actually find this particular article by the title itself. So when you will Google ERS and ATS statement latest, you're going to get this document. It is a very good document. It will help you understand a lot of things. And it will recapitulate this entire talk. As for cellular NSIP and infections, so your clinical presentation is going to be very different. In thoracic radiology, you cannot interpret the CT without clinical findings. So first clue will be lower lobe predominance, ground glass predominance, that too bilaterally. It may be asymmetric or symmetric, and the patient is not going to have an acute presentation of fever, something like that. It's going to have more of breathlessness, a slow insidious course. So you have to see those things in mind also. Infections usually will be unifocal or they will have a more of a consolidation or a ground, like they are going to be multifocal, not in this lower lobe predominance. So that is how you will differentiate cellular NSIP from any infection. Background clinical history of infection and versus a chronic slow course, NSIP is not going to present acutely. So clinical presentation, infection ka stigmas, and lastly the pattern, bilaterally asymmetric or symmetric, lower lobe predominant ground glass is can be associated with other CTDs like connective tissue disorders, other kind of complaints, clinical complaints like arthralgias or other kinds of CTDs, even Sjogren's, so that is how you differentiate between NSIP and infection. Again, now there is one more important thing that I have to tell you, that if you look at the reason why we need to figure these things out is they are going to progress into pulmonary fibrosis. These are progressive in nature. We have to find them and correct their path. That is why the UIP pattern, if idiopathic, has a very poor prognosis. Whenever there is an underlying cause, if you can capture that cause and treat it, that's when it becomes important. Your prognosis changes. Number two, if you look at UIP and NSIP, suppose you are doing lung biopsy for a patient, you are confused whether it's UIP or NSIP. UIP itself has temporal heterogeneity. This is the main takeaway point. That means that within the same lung, you are going to have varying stages of fibrosis. So what happens there is that you can have cells infiltrating into the alveoli, into the alveolar septums, interstitiums, And you can also have fibrosis at places. So sometimes when even when radiology pattern is UIP and the biopsy is done and you get NSIP at some place and UIP at other, that means that it is a UIP pattern because temporally these parts are different. Look at NSIP like a pathway of fibrosis, that it is cellular initially, then it becomes fibrotic. So temporal heterogeneity is a hallmark for UIP. If there is temporal and spatial homogeneity, that means all the parts of lungs look similar in stage of fibrosis. The whole lung is fibrosing together. Either it's all in cellular phase or it's all in fibrotic phase. That is very, very important for histology of NSIP. Because if you will go back to the title of this talk, it is multidisciplinary. You need a pulmonologist, you need a histopathologist, you need a radiologist and a rheumatologist. That's how the ILD MDTs are conducted. Without all these specialties, you cannot diagnose ILD correctly. So, NSIP, we have understood what is the typical pattern. If you look at such a finding and you see this kind of pattern, the chances of you getting it wrong are very low. Next, let's go on to airway centered interstitial pneumonia. So, the concept again here is that everything is entering through the airway and that is inciting an inflammatory response. So, it can be hypersensitivity pneumonitis, it can be inhalational exposure, it can be aspiration, or it can be because of medications. Again, now let's look at this. So for BIP, the prototype, prototype means कि most classical cause will be what? HP, hypersensitive pneumonitis. Because BIP can have two varieties, fibrotic and non-fibrotic. So if you look at non-fibrotic, it's first of all, it may be hard to understand, but you are finding these ill-defined nodules, ground glass. Can you see? They are diffusely scattered. This is not a normal lung. There are multiple ground glass nodules scattered in both lungs. They're profuse, they're ill-defined central lobular nodules. So this is all airway-centered inflammation. It's non-fibrotic. You don't see any kind of fibrosis. Vis-a-vis, if you look at this, and also because this is airway-centered, in this you can also find, apart from the nodules, you can also find air trapping, GGOs, mosaic attenuation. So that just means whenever there's air trapping, that means that there's some kind of bronchiolar edema. So air is going in, but it's not able to come out. Because while we expire, they're going to collapse airways. So they're already edematous. So everything is going to get trapped. If you look at fibrotic, now what are we seeing here is that the fibrosis is not like the one which we saw earlier, right? It's not here. It is more in the peribronchovascular distribution. That is number one. But there is fibrosis because I can see that this airway is beaded. This is not like a smooth airway, na, which is going to taper like this. No, it is very beaded, it is dilated. So there is this peribronchovascular distribution of fibrosis and tractional broncholectasis. Next, you are having areas of ground glass opacity, normal lung, and you are having this air trapping. Air trapping is an area of lung lucency. So what happens is because more air is trapped inside, so lung becomes darker. So you have this area of air trapping. So whenever you are finding these things, you are thinking about an airway centered fibrosis. So that becomes your fibrotic BIP. Okay. So what has happened is that HP, there were new guidelines for hypersensitivity pneumonitis. But this new ILD update is saying that you call it bronchiolocentric interstitial pneumonia. And then you can favor hypersensitivity pneumonitis as a cause, that you think that this may be the cause. That we'll read in our last page recommendations. So These are the three major patterns. You have to identify these. There's no running away from this. ये तो तीनों identify करना ही है always. Out of these, I would say that LIP is something which you can very easily start picking up. Next will be pleuroparenchymal fibroelastosis, and last is DAD. So hard to understand diffuse alveolar damage. The name has alveolar, but I'm still saying it is in the walls of the alveoli. So it goes into the interstitial pattern involvement disorders and not alveolar filling. So what happens is in the walls, there can be initially an inflammatory exudate. The cells are all filling in that septa and later on fibrosis starts in that places. Clinically, how does this patient present with ARDS? Acute finding. It has phases, acute and organizing phase. So patient is acutely ill for DAD. ARDS has to be there. It has many causes. Look at it. Infection, drug, inhalational injury and CTD. So it has many secondary causes. Because the patient is so sick, there's no question of any biopsy. We don't do all that in these things. No lung biopsies here. Next, if you look at pleuroparenchymal fibroelastosis, so first I'll show you DAD. Okay. So in diffuse alveolar damage, what is happening is that you're finding these areas of ground glass bilaterally symmetrical and they can coalesce to form consolidations. Okay. And they're going to be bilaterally symmetrical and in a poor oxygen saturation in the background, you can actually call it like a diffuse alveolar damage pattern because it has numerous causes. It can have infection, it can have drugs, it can have inhalational injury, it can have CTD related changes, it can be anything. Okay. Next, if you look at pleuroparenchymal fibroelastosis, what happens here is this is an upper lobe predominant disease. Look at the upper lobes. Next, it is going to cause subpleural areas of confluent fibrosis. ये पूरा fibrosis है in the subpleural location. PPFE itself has many causes. If we go back to the table again, we are going to find a lot of causes for PPFE, like infections. And so if you look at this, you can have it associated with IPF. You can have it associated with CTDs. Think of transplant related changes. You can have it post tuberculosis. You can have it in occupational lung diseases, radiation, medication. So this has many secondary causes. Once you identify this pattern, then you can think of secondary causes and then try to go ahead with this. Okay. So here what happens is that you have a biapical subpleural parenchymal fibrosis with pleural thickening. How to differentiate it from just apical pleural thickening is that it's going to cause volume loss and it's going to involve both anterior and posterior part and it's going to extend up to the major fissures. Okay, so it's going to cause significant fibrosis, then only you can going to call it into this pattern. Next, so I'm just going to write down PPFE here. Always look for secondary cause. Okay. And this is a diffuse alveolar damage. And you can see that there is this ground glass and consolidative pattern in the background of ARDS. That's when you're going to call it this pattern. Okay. Next, this is your lymphoid interstitial pneumonia. What happens in that is that you can have multifocal ground glass, like small areas of ground glass, ill-defined nodules, or you can have diffuse GGO. Like look at this lung, look at this one, it's diffusely whiter, right? So what is happening is if you look at this, so PPFE, remember biapical, both the upper lobes. Yeah, so both the upper lobes. So just apical pleural thickening means कि just pleura has thickened. Here I am saying there is pleuroparenchymal fibroelastosis. That means fibrosis भी है, pleura भी involved है, parenchyma भी involved है. Here what is happening, if you look at these airways inside these consolidative areas, Why these are looking like consolidation? Because you can see airways inside. But this airway is not normal. This is not a normal air bronchogram. Your airway is irregular in shape and it's reaching up to the periphery pura. This is all dilated because of fibrosis. All this is pleural thickening. All this is parenchymal fibrosis. And there is going to be volume loss. There is a traction on this airway. ठीक है ना? Your airway is getting pulled to one side. And there is all subpleural areas of consolidation. You're not finding it here. You're finding it all here. So volume loss, bilateral parenchymal fibrosis in the subpleural location, apical predominant. If you see it is involving both anterior and posterior part, no predilection. Apical pleural thickening में क्या होता है? If only your apices are just thickened, but there's no significant volume loss. How do you say that it is volume loss? Because what happens is your hilas get pulled up. Okay, that is number one. There's a volume loss in the upper lobes. It's a bilateral upper lobe predominant thing. So fibrotic component has to be there for us to think of PPFE. I hope you are able to understand PPFE now. बस उसका you do the full form of it, right? Pleural parenchymal fibrosis. Okay. So after this is done now, so for lymphoid interstitial pneumonia, you may have diffuse GGO, you may have focal GGO, and you are going to find randomly distributed thin walled cysts in both the lungs. Nearly 70% of the cases. So this is what is your LIP pattern. Again, LIP, if you see, you have to think of a secondary cause. If you think of secondary causes, you have to think of CTD associations, Sjogren's, SLE, RA. You have to think of immunodeficiencies. You can think of HIV, EBV, human T lymphocytic virus, right? So all these are causes for this. So when you see this, just don't stop here. We cannot just say कि ये idiopathic है. We are going to say कि look for these things. Because when we'll be able to treat these things will also improve. Yes. So even in children, yeah. So HIV associated chronic infections, immunodeficiency, immune modulations in CTDs, all this is going to cause that. How are you going to identify it? You're going to find diffuse or patchy GGOs, you're going to find centrilobular nodules, and you're going to find thin walled cysts randomly distributed. Okay. So that's how we are going to think of LIP. So these were all of our interstitial pneumonias. Three were very major patterns, we've understood them. Three were lesser important, but still you're going to find them a lot in your practice. Those were done.